All right, Dr. Sharma, you're on.
Okay, the lively discussion, and we want to finish it by 9:45. This will be 5 minutes late.
7 minutes.
Okay. Yeah, so 7 minutes is good enough. Yeah. So, okay, starting with this case, I just want to first introduce my team here. Amit Hooda is my right-hand man and is always helping all my complex cases. And then we have our two fellows here, Bora and Anton Kamaj. Then we rest of the staff. I'm sure with the live cases, everybody has seen the same. Ashley and Vicky here, and Imaging Kiski will be both places, and technicians is Ramon and Habib. And so basically, this is the case number 2, keeping into the plan of the left main. So this is the right coronary. This is as you can see, it's an 86-year-old female, was presented to outside hospital, EF near normal, and 3-vessel disease, declined cabbage, risk factors on the left side. What we did this time is we have added everybody A1C, LDL, creatinine, and CRP. Because of age and so patient came here. Syntax score was about 23 plus. The right coronary is good. And why the syntax score was trouble was, look at the before dye given. So I always say, you need to have injection to see the calcium. We have to show we can go to the angio now, please. So appropriateness point of view, this patient is a left main with a moderate syntax score will be Excel trial case, so they will be okay. You don't need a heart team discussion really if it's less than 32. But this patient was declined from outside. And let me just show the RCA before we go on. RCA is good. And left main, look at the calcium. Tremendous amount of calcium in the left main and the proximal LAD and the aorta. See the aorta calcified. Circumflex actually is, this is an important point. Any left main disease, whether it involves only one vessel or two vessel, this case is a clear-cut osteal disease, and then very tight LAD. The circumflex on the angiogram looks okay, mild disease, so it will be less than 50%. So we can just say that from bifurcation point of view, this will be 0, 1, 0. That osteal LAD, and on top of it, there is the osteal, the left main disease. So I know with the time constraint, what we did is we went ahead, knowing there's so much calcium, we did a 1.75 bird, tremendous slow flow. We got transient high, the ST elevation. With this, first we did the we used the rota extra support wire, osteal left main. Then LAD was very tough with a 1.75 bar. That's where caused the slow flow, but transient. And can we show the EKG also, please?
So it also looks like she kind of stopped her heart rate, slow flow, and also like
they're very important. Then patient also developed
hemodynamic compromise here.
Yeah, usually, as you know, this patient, we were thinking originally that should we put a balloon pump or not, or Impala probably would have been knowing that the right is normal. Second, it's not a bifurcation left main. And the third, EDP was normal, and the ejection fraction about 60%, we felt, let's say without it. So clearly, we'll say that you put a pacemaker only on the right side, but we have seen many of the left mains also become asystolic. So this patient required atropine. We are almost close to putting a pacemaker, but didn't need it. As you pointed out, clearly getting slow flow and the bradycardia. So this is then we dilated with the 3O balloon, and then we did the IVUS, and maybe we can show the IVUS run now. Yep. So IVUS, we are concentrating on two things: osteal left main and the proximal LAD, and also look at the osteum of the circumflex. So now,
yeah, to me that circumflex is not looking pretty, but maybe I'm wrong. But let's see.
This is the prox LAD, like a 360 calcium, and eccentric. Now come to the left main. Interesting point is the osteal left main has a like elastic calcium nodule.
And there is a calcific nodule on the osteal left main. But do we know what's happening in the osteal circ? Or do we need to do extra IVUS in the osteal circ? That's the question was.
I would say I think you need to IVUS that osteal circ. Anyone else? Or am I the only?
But I mean, by the IVUS looks okay. Look at that. I mean,
well, that's a side view, which is like half of the view.
Yeah. Because on angiogram it looks
no downside to looking at the osteum
of the circumflex. Dr. Sharma, good morning.
Yes, very good morning, my friend. Yeah, Praveen. So the question was, so we felt that, you know what, the time again, age, taking all the factors together, I said, since angiographically, and I was kind of indirectly, not without doing the ostial circumflex. We said that probably we need to just work more on the left main and LAD. And let's go back to the angiogram. So what we did is after dilatation with the balloon, and then the ostial left main, So what we did is, this is the IVL. Then we did the IVL, and you see that left main IVL. We'll also say that if you don't have hemodynamic support, I know what happened on the other side, that despite the impella, there was the IVL of the left main called hypotension, and I'm teaching do 5 pulses. Don't do 10. 5 seconds, let it breathe, do another 5 seconds. So this is what we did for the left main, and of course was significant hypotension. We had done that.
So you broke up
clearly,
the pulses to reduce the hemodynamic compromise.
Ischemic time.
And I applaud you. You didn't
exactly.
put an impella in this frail little lady.
Yeah, exactly. So this is now it's a 3.25, 33 Zions. And this is where we have dilated, and we are here now. So we are ready to do the IVUS, and now we'll decide whether we need to go and kiss for the circumflex or just post-dilate the ostial left main. So everybody,
if you're not going to IVUS it, maybe you can do a better angiogram so we could see that better, maybe, because it's not a really good view of that circumflex, Dr. Sharma.
No, we'll go to the epicaudal. Yes.
Any comments any comments, any questions from the panelists?
Well, see, this is kind of interesting and juxtaposed to the previous case that, we've got somebody who's having a complex left main, ostial and potential involvement in the bifurcation. They were getting ischemic time with the rotablator, we're getting slow flow, but we're not using an impella.
Yeah.
And see, there's clearly a gray zone.
It's a randomized trial here. One room used the impella, the other room didn't.
Yes, you got your own randomized trial.
Okay.
But it's what you said, John. Not all chips are alike.
That's exactly right, and that's the point. Exactly. I mean, there is a gray zone here. The deciding factor on the previous one was the pulmonary hypertension, primarily, even though most of the other factors are the same, excluding the AS, which you've already taken care of.
No, I agree. I think the aortic stenosis, pulmonary hypertension, measuring hemodynamics before you do it, even though ejection fraction is normal, is critical. Here, listen, the hemodynamics were fine. Everything was good. Patient is preconditioned, doesn't have aortic stenosis. These people tolerate the procedure very well.
Dr. Sharma, that looked very good.
Okay, tell us now.
Maybe if you had I'd like to know if you had a drug-coated balloon, would you just do a drug-coated balloon and come out and not give her a stent? Looks really good on IVUS.
In the large vessel? No. In the left main? I mean, I know some data for the large vessels are there. But
this is what people are talking about, and I think we need trials, absolutely.
Roxana, can I bring up a point about drug-coated balloons? Unlike IVL, where you can shorten the time interval, say come down to 5 seconds, if you do that with a drug-coated balloon,
you're not going to get
you can't use it again, and you just threw away $5,000.
Yeah.
And
so there is a few millimeter expansion outside.
You know, people say you do imaging in calcium. It adds to your cost. Imaging actually adds to your cost, because when you look at the left main ostium, the rota actually went the other side because of the bias, and you didn't do anything with the nodule. So now you know you have a nodule. And so for you to really get a good luminal gain, you have to do RotaTripsy like you did. So, and that's why the stent really expanded the way it has expanded. So even though we understand calcium beta, I think, when we do it properly, it adds to the cost.
No, and I think imaging is just so key in these cases.
Proximal LED is good.
And we're seeing about, more and more infiltration of imaging, but you could see that this kind of a case absolutely needed imaging. And I think it helped you a lot, Dr. Sharma. What do you think? I
mean, the plus yes and no, but just to say the importance of the imaging. Yeah, so no, the key is the data, from NCDR, they've presented the data that experienced people who are more than 5 year, 10 year, or senior. So it turns out to be the benefit of imaging is in all across, but was significantly higher in people who are in practice less than 5 years. After 10 years also, which probably will go into that category, benefit was there, like p-value of 0.058. But compared to other group, it's like 0.02, 0.01. So yes, the question I would say, if imaging has to help in this particular case, will be that whether ostial circ is truly involved or not. That to me will be the big one. So right now we are dilating with the 4O. Because the left main was 4O. We know the few millimeter stent is coming out in the left main. We wanted that because the ostial, you always had to have few millimeter.
7.3. Huh? It's not a perfect. Ostial left main area is 7.3. That's why it's good to do the post-dilatation.
Okay, so therefore it's a 10.3. And let's see now, we take a good picture and take a idea of the circ. Now, remember many times, if you people recall, remember in October trial, like 25% were the left main. There was a stent distortion by the guide catheter in 10 to 12% of cases. So very careful. We always say, once you have put a stent in the left main, you make sure you advance your guide on the balloon.
Yeah.
Your alone guide will invert your ostial stent, and that was seen clearly in the October trial, that stent deformation with the in the left main cases.
Excellent point.
Okay.
You definitely don't want to miss the ostium, and remember that the left main is not flush perpendicular to the aorta, right?
Yeah.
So to cover one side, you have to have some degree of protrusion on the inferior side, and if you miss that, you've missed everything. And you will have more of it. As a result of the protrusion, though, you do have some propensity for distortion.
Okay, so let's see now, Kiski here. We are going to do just short IVUS from the proximal LED to see what is happening into the circumflex, or should I go through the stent struts? I feel that if we are not planning to go through the open with the kissing, I think we should leave it like virgin. Don't distort it, and because everything looking good. No ST elevation, patient feels fine. No ST depression. So to me, looks like the circ should be okay, but we'll taking another good look at with the left main. Proximal, we are dilated with a 4O, non-compliant balloon at 24 atmosphere. So became probably 4.25, I would say. And this is where we are. Just we want to do the short segment. 1 second.
Yeah, okay, stop.
Yeah. Want to just concentration. Okay, I was on the main screen, please.
No,
This is one comment for take-home message today, for take-home message. Is the calcified lesions better approach always with lithotripsy first, and if they doesn't work, go to Rota, or would you modify that statement that Dr. La Sala said a little bit about?
No. I think La Sala said the same thing. La Sala, there is a publication in the circulation intervention, or JAC, one of them, just a few months ago. What had happened from the ACC and CDR? So before IVL, the introduction in 2 years, and so now IVL is the one has really skyrocketed the use in this calcific lesion. Is about 6% use in the United States. Now, before 3 years ago, the orbital atherectomy use was about 2.1%, and rotablation use was about 3%. So what has happened? Both of them have decreased about 0.6 to 0.8% rota as well as orbital atherectomy. With little decrease, less than 1% decrease, but combined 2% decrease. But IVL has taken up to 6%. So if you take now, which I always been saying that 10% lesions are severely calcified, we need to modify those lesions. So that is happening at present, combination of the IVL and atherectomy. So what La Sala said, that 20% of cases are done with atherectomy plus IVL, but majority of those cases, IVL is done post rotablation, and that's what we do. I yet to do a case where we did IVL first and then rota, because IVL key is we will know which lesion if you can advance the IVL. There's no question in my mind now for most of the people that if you can advance the IVL, you don't worry about rotational atherectomy. IVL will do the job. It will be very rare that you'll not break the calcium with IVL. But half of the cases, like ours, like this case, I can tell you, IVL would not make a turn on that proximal LED, guaranteed. Therefore,
okay. Dr. Sharma, you're cutting into all of everyone's time now. We have to keep going. So let's hear about what you are going to show us now on this very, very good point about the IVL.
Roxanne, we can save a lot of time because Tamim just gave my lecture. I can cut that out.
Yeah. Okay.
Yeah,
no.
cut it out.
Well, okay, guys. Good. Done. This is our last picture. We have shown the IVUS. Tell us IVUS.
Yeah. Final MSA, the ostial left main 11.
Okay. What is the ostial circ?
Yeah.
And he's saying the ostial circ is fine. not compromise, so do nothing to the ostial circumflex.
I would like to see a picture of an angiogram of the ostial circ. A good RAO caudal where I could actually see that circ. I've never seen it.
That's where we are. Okay, that's where we are.
So I think this is excellent points to be made here, and that
Although it looks a little
Jazz
heavy.
alluded to this earlier, that IVL has more
Looks a bit
flexibility.
hazy there.
Handling superficial and deep calcium, as long as you can get it across there. But atherectomy becomes mandated when you can't do those things and you want to expand it further. That's when it becomes very important.
So based on what I see on the angiogram, Dr. Sharma, at the very least, I'd like you to cross and just do a little kiss. But if you don't mind, I'm going to go to the other room.
Yeah, you go.
And then come back to you.
No, don't need to come back. I think you just start your session.
Okay, thank
on
you.
the preventive. Yeah, we are completely just made all the points, and it's right there.
Beautiful.
And we'll just do the kiss because of the ostial lesion. Although IVUS is not helping us in that way, we'll do it without it and just do a kissing.
Yeah. Let's just see the final results on the other side, and then maybe you'll bring it to us or show it to us at some point on the screen later. Thank you so much. Wonderful, wonderful case. Thank you.